Hello, my name's Florence. Welcome to theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 99. Let's talk about sex. This topic has been a really slow burn, one I've been mulling over. As so often, it's something that was prompted by listening to something else. In fact, it was because I was listening to Jill with her Wildcard Whose Shoes podcast. And the episode I was listening to was the one with Rachel, rocking two stomas. She talked about the fact that it was difficult as a young woman with two stomas to broach the subject of sex. Doctors and health professionals just didn't broach it. Now, of course, that hasn't got anything to do with pregnancy or birth. But it made me think. For a specialty that deals exclusively with the reproductive and genital tract organs and illnesses, how can we spend such a small amount of time thinking about sex and sexual function? I learnt to do vaginal surgery, both in obstetrics and gynaecology, with a knowledge of anatomy, it's true, but with very little thought about sexual function. Does it matter? Maybe it doesn't, but maybe it does. If one of the most important functions of the vagina, vulva, labia, clitoris are sexual, then if we don't talk about it and we don't think about it, aren't we likely to be missing significant effects? I thought, therefore, that an episode on sex in pregnancy and postnatally would be a really important one. It might help women, but equally it might help us, healthcare professionals. It's somewhat bizarre that we find ourselves struggling to have these conversations. In the first part of this episode, I'm going to talk a little bit about sex during pregnancy. And then in the second part, I'm going to be joined by Swati Jha, a consultant colleague from Sheffield, who wrote a fantastic article on female sexual dysfunction, which I read, and that's how we connected. Sex in pregnancy is something we don't really tend to talk about, which is somewhat odd given that the majority of women we're seeing will have got pregnant that way. Of course, there will be some that will have had fertility treatment, IVF, IUI, or those that are not in a cis heterosexual relationship. But we can seem to ignore the topic. Apart from random moments when it suddenly pops into the conversation. One such moment is if a woman attends with vaginal bleeding during pregnancy. One of the questions we ask is, was it after sex? This may seem an unnecessarily personal question, but really for us, all we're trying to find out is, is this bleeding provoked, i.e. the result of something within the vagina, or is this unprovoked? Nothing potentially triggered it. In actual fact, we're hoping it is after sex, so-called post-coital, because that's a very good reason for bleeding in pregnancy. Usually fairly light bleeding or spotting, because the surface of the cervix changes due to hormonal changes and becomes a little bit more fragile, and therefore bleeding can be triggered much more easily. Bleeding of this sort after sex can suggest to us that there's actually nothing wrong with the pregnancy, and that the bleeding is coming from the cervix, the neck of the womb, and is actually nothing to do with the pregnancy, the placenta, or the growing baby. So, whilst it seems a slightly unnecessary, intrusive question, it gives us very valuable information. The other situation in which we will start randomly talking about sex is right at the end of pregnancy. Maybe the baby's overdue. Maybe you want to avoid an induction that is being suggested for some reason. We will suggest having sex because semen contains prostaglandins, the same hormones that you release to go into labour. But for the rest of the time, on the whole, we don't mention it. It's taboo. So, what about sex during pregnancy? Is it safe? Yes. On the whole, it absolutely is. There's no need to worry about the baby or the pregnancy. The baby is very well protected by the neck of the womb, the cervix, which is long, 3 or 4 centimetres in length, and closed. The baby's nowhere near the vagina, and it's only in quite rare situations that we advise against sex during pregnancy. So if it hasn't been mentioned by your doctor or midwife, sex during pregnancy is absolutely fine. There is some lovely NHS information, including a little video, as well as some good information from Tommy's about sex during pregnancy, which I've enclosed in the programme notes. And this information from Tommy's also details the small number of situations in which we would suggest you don't have sex during pregnancy. So there you have it, sex in pregnancy, perfectly safe. For the remainder of the episode, we're going to think a bit about sex after having had your baby. And for that, as I mentioned earlier, I've got a special guest. Thank you so much, Swati, for joining me today. I came across you because I read your article in the Obstetrician and Gynaecologist, which is mainly for our kind of continuing professional development. And I was really pleased to see your article because I really hadn't come across anyone talking about sexual function, which sounds a bit crazy given that we're obstetricians and gynecologists, and what we do all day has quite a lot of relationship to sexual function, I would think. I emailed you and you very kindly got back in touch. So could you tell us a little bit about yourself and sort of how you're interested in this topic?
Yes. First of all, Florence, thank you for inviting me to speak to yourself today. First of all, a little bit about myself. I'm a consultant gynecologist and I subspecialise or superspecialise in urogynecology. And I got involved in sexual function because this was the subject of my MD thesis. So going back over a decade, I wrote a thesis which was related to sexual function in women who have urinary incontinence. Incidentally, I also was running the perineal trauma clinics. And what I found was a lot of the women who were presenting in clinic were not necessarily just those who had had anal sphincter injuries. That's a more severe type of tear, as we know. But they were presenting with problems of sexual dysfunction following childbirth. So that made me more interested, realised that there was a gap in the services we were providing. And what I've ended up doing is expanding the service of the perineal trauma clinic so that not only do I have one clinic where I see exclusively women who have had what we call an OAC or an obstetric anal sphincter injury, but I run a parallel clinic where women who have not had an OAC are seen because they may have a variety of different problems. And the commonest problem I see in that clinic is actually problems of sexual dysfunction for a variety of different reasons, which I'm sure we're going to come to in due course.
And when they come to your clinic, is that how they start the conversation? Because one of the things that interested me in your article was a very simple, straightforward suggestion to clinicians about how they might broach the subject, and that we might need to broach the subject because women may not want to, or may be embarrassed or fearful of talking about it.
So no, absolutely, they do not come and tell me that that is their primary problem. A small proportion will. But if patients are largely embarrassed to talk about their sexual function, as doctors, we're even more hopeless about broaching the subject.
Yeah.
So one of the things I will always say to medical students and trainees who are with me in this clinic is that you have to think of the pelvic floor as having 4 domains. There's a urinary domain, a vaginal domain, a bowel domain, and a sexual domain, and that the sexual domain is as integral to the pelvic floor function as any of the other 3. So it cannot be ignored. If we are asking about prolapse, we cannot not ask about sexual function. So it has to be an integral part of the questioning. And the other thing I see a lot of in, not just in my perineal trauma clinic, but in my urogynae clinic, is women will attend clinic with supposedly a different problem, a problem of prolapse, a problem of urinary incontinence, when actually what they want to talk to me about is their problems with sex. But again, if you don't broach it with them, they won't necessarily be comfortable talking to you about it. So the onus of responsibility is very much on the clinician to bring that up so it makes the patient feel at ease. And I have to say, Florence, I've lost count of the number of times that patients have gone away saying, thank you so much for bringing up the issues of sex because I was so embarrassed to talk about it.
Yeah, I can imagine that. And you put in the article, do you have any concerns about your sex life? And that just seems so straightforward. And yet I think you're right. As doctors, we struggle. And I certainly don't remember really having any training in properly talking to women about sexual function or even sex at all. And I think I find that a bit odd. It's kind of ignored.
I agree. And if a gynecologist isn't going to talk about it, or obstetrician gynecologist isn't going to talk about it, who is?
Yes, absolutely. And when we talked in preparation for this, you also mentioned something about women's expectations of how giving birth and having a baby might change their physical appearance or physical feeling of how their vagina might feel, but also how sex might feel or how sex might be after having a baby. And I thought that was a really interesting thing, because if we don't talk about sex at all, then we're never going to get on to actually this might change after you've had a baby.
Absolutely, Florence. Again, we don't educate women as well as we should do to inform them that any type of delivery, whether that's a vaginal delivery or a cesarean, will result in changes to their sex life. Now, cesareans have their own host of problems, pain with a scar, and if you just think about it, the discomfort caused from the adherence or the sticking of the bladder to the uterus after a cesarean can cause pain with sex, on penetration, whereas with vaginal deliveries, they bring with them a slightly different host of problems. Those being the fact that the vaginal wall is inevitably or quite often left laxer than what it used to be. And the opening, the appearances of the vaginal opening following a vaginal delivery change. And again, these are things that we don't tend to talk about. Hence, I see a lot of women, particularly women who've had their first baby, who are quite convinced that they have a prolapse because they can see the inside of the vagina. And I spend a lot of time convincing them that this is normal.
Yes.
So normal changes are perceived as prolapses and abnormal findings because we just haven't talked about it enough.
And do you think that's also, so you mentioned in the article quite high rates of pain, certainly in the first few months after having a baby. So in the first 3 months, I think you said 83% will experience problems, which then over time will lessen, but they won't ever get back to the same level as before having had a baby. So do you think the kind of combination of pain, new motherhood, having a baby to look after, and that having an effect on sex then perhaps gets attributed to the physical changes erroneously?
I do. And there's one other factor that plays hugely into this equation. And that is the first thing I ask women when they come to my clinic postnatally. And that is, are you breastfeeding? And the reason I ask this, and I use the analogy of breastfeeding being nature's contraceptive, because before the times when we had such effective forms of contraception, nature's way of controlling population was for breastfeeding to impact on a woman's libido, make her vagina generally feel sore because her periods haven't returned and so the estrogen levels are suppressed, and for those reasons, for sex to be generally not pleasurable. There is plenty of research out there which shows that when women are breastfeeding, there can be more pain for those reasons. And particularly reassuring as a counter argument to that is the fact that when women stop breastfeeding, whenever that may be, within 4 weeks of cessation or stopping breastfeeding, they notice an improvement. Now, what I will always say to women is that's not a reason to stop breastfeeding, but that's a reason to know that things are reversible. Things will go back to being better whenever you decide to stop. I will also mention treatment options while women are breastfeeding. And whereas the use of vaginal estrogen creams is off license, for a woman who has been breastfeeding for quite a while, who's experiencing considerable soreness, it would be a very reasonable treatment to offer and provide, making the patient aware of the fact, obviously, that it is an off-license use.
Yes.
So, yes, in terms of the points you mentioned earlier, I would agree with all of those. The impact of tears, which are more common after first pregnancies, the impact of changing physical appearances or physical changes in general, and the effects of breastfeeding. Forget the late nights, lack of sleep, changing diapers and all the other things that go with having a newborn.
Yes, yeah, completely. I think I was really struck by what you said as well about actually this being something that would improve over time. And that came through really clearly in the article, that actually women need hope that actually this isn't forever. It is going to get better as the months pass, and it is going to get better once they stop breastfeeding, whether that's 6 months, a year, 2 years, or however long it's going to be, but that it's not going to be like this forever. So that difficulty perhaps in the first few months after having a baby shouldn't make them feel despondent.
Absolutely. The other group of women I see who are exceptionally pleased once they've spoken to me is the ones who have nothing wrong with them, who have just been reassured that what is happening with their body is normal, and what will happen over the next few months will be improvement as time goes by.
Yeah.
And it's amazing the number of relieved women who leave my clinic consulting suites and say, thank you so much for just reassuring me that this is all normal.
Yes. And I remember you saying to me that actually, given you have the clinic that looks at perineal trauma, tears and problems, that actually you do the least number of Fenton's procedures, Fenton's being a procedure to kind of release perhaps scar tissue at the opening to the vagina, than any of your colleagues. And that really struck me, that actually having surgery isn't necessarily the answer. It's understanding and looking at other things rather than just sort of trying to, I don't know, do something for the sake of doing something almost.
Definitely. I mean, I've noticed this. I've been a practicing gynecologist for 25 plus years now. And this is something that's always struck me, that we're very quick as surgeons to offer a surgical option. But many a time, a surgical option is not the solution. And given I run those clinics, you would expect the maximum number of Fentons to be done under my care. But actually, I don't, because the only thing a Fenton's addresses is the opening or the capacity of the opening of the vagina. It doesn't address soreness. It doesn't address pain with deep penetration. It doesn't affect libido. So it's just the penetration. And quite often what I will do when women come and say to me, my vagina is too tight, there's too much scar tissue, or that's what the GP has told them, or that's what another gynecologist has told them, I will first win over, hopefully, the trust of my patient, and then very gently perform a speculum examination to demonstrate to them that actually, if I can do a speculum with no discomfort, they definitely do not need a Fenton's.
Yes.
And this is where perineal massage has a role to play. This is something we teach patients antenatally to reduce the incidence of tears. But the minute women have had their babies, we forget that actually this has a huge role in breaking down scar tissue or helping scar tissue become softer, more supple in the postnatal period. Not while the stitches are still raw and fresh, obviously, but once the stitches have healed, perineal massage has huge benefits. And I will always ask patients to do a course of perineal massage, try dilators, a variety of other things, try different positions during sex, etc., even estrogen if they're breastfeeding, before we go down the route of surgical options such as Fenton's. Because what does a Fenton's do? It causes more scarring, more pain, and can make the situation worse.
Yeah, that's a really interesting idea, the thought of perineal massage postnatally. I've definitely heard about that in relation to cesarean scars, but I've less heard that in relation to perineal scars. But
you should come and sit
you're
in my
right,
clinic.
we're telling everybody from 34 weeks, do your perineal massage. But we're not then continuing to do that. No,
I'm making up for it by asking everybody to do perineal massage in my clinic.
Fantastic. That's really great. The other thing I wanted to ask you about was women who are worried about delivery because they've got perhaps sexual problems pre having a baby. So because I run a birth options clinic, I sometimes see women who perhaps come with a history of vaginismus. They find it very difficult to have sex. They find sex painful. Sometimes they've struggled to get pregnant because of that. And they're very fearful about tearing and traumatizing the vagina when they've already got existing problems. So I wanted to know what you feel about that, or what advice you have for women for whom that might be an issue.
So the first thing to emphasize is that vaginismus does not get better with a cesarean section. And again, in my clinic, I see lots of women who had pre-existing problems with sex, choose to have a cesarean, and lo and behold, they still have problems with sex postnatally, because a cesarean isn't going to make things better. Now, I'm not saying to you that a vaginal delivery will make things better. So in this day and age of patient choice, the important thing to emphasize in these patients is that if they have vaginismus beforehand, they will still have it after the delivery, but especially so with a cesarean.
Right.
With the vaginal delivery, at least if the vagina of the pelvic floor has been stretched, which is what happens, I accept there may be tears, but in the vast majority, those tend to be relatively simple tears and do not cause problems going forwards. There is no added advantage. The other thing we have to focus on is, or if we look at, is the statistics for pain after a vaginal delivery and a cesarean. And in the article, again, I've quoted that I think it's at 6 months where they become equal, irrespective of whether you've had a cesarean section or a vaginal delivery.
Yes.
So dyspareunia rate, or pain with sex, is not different depending on the mode of delivery. It may be in the initial months, but at some point the two are at par.
Yeah, I think that's something I really took away from the article, because I'm ashamed to say it surprised me, because I hadn't thought about the fact that potentially the benefit from a cesarean would be so short term. I found that very interesting. I normally end my episodes with a bit of a zesty bit, a bit that people might take away and do differently or think differently. And it would be good to have your thoughts. I think from talking to you, I'm thinking for health professionals, probably it's to broach the subject in the first place and make sure they know the information that we've discussed. But for women, what would you say?
I would say don't be embarrassed to talk about your problems. We're here to help you. And if you ask for help, we will, give you a range of options that you can consider to improve things going forwards. If, however, you keep the problems to yourself because the doctor hasn't broached the subject, all it will lead to is frustration. Frustration that the consultation didn't go to plan, frustration that the doctor should have asked. And I admit we should be asking, but in those cases where doctors haven't asked, I think women should volunteer that information, and freely. If sex is considered such an important part of a male or a man's well-being, mental well-being, his emotional well-being, why should it be any different for women? And men seem to be able to talk about their sexual problems so much more easily than women do. I don't see why there should be any difference whatsoever.
That's a really interesting point. And you run a very specialist clinic and you're a specialist urogynaecologist. So I suppose the other aspect would be to get your GP to refer you to your local specialist clinic, if there is one.
Yes, most hospitals will have a perineal trauma clinic, which I would admit is usually dedicated to the management of patients with anal sphincter injuries. But whoever the specialist managing an anal sphincter injury is, they will be very well placed to manage other problems related to postnatal perineal issues.
Thank you so much. It's been really fascinating and informative, and I'm really hoping this episode will help a lot of women feel a bit more confident in what's happening to their bodies and how to seek help if they're worried about things, but also will hopefully help some healthcare professionals open up the conversation and not feel daunted by it.
Absolutely, Florence. And I do hope, women out there with problems go and speak to their doctors. Thank you for having me on the programme.
I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FW or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.